Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine you're scrubbing in for a major case.
Yeah, we've all been there.
Right. Your patient is prepped, the team is ready, but you glance at the pre-op chart one last time and see a HAS-BLED score of 4.
Oh, that's a stressful moment.
Totally. I mean, your immediate gut-level instinct is likely to cancel their anticoagulants right then and there so they don't, bleed out on your table.
Exactly. It feels like the safest decision you could possibly make.
It really does. But what if acting on that instinct is actually the exact opposite of what the science dictates? Welcome to today's deep dive.
Thanks for having me.
Of course. Whether you're prepping for tomorrow's list, catching up between rounds, or running a busy preoperative clinic, we are speaking directly to you, the surgeons, the anesthetists, and the doctors on the front lines.
It's a crucial topic for that exact audience.
It really is. Our mission today is to completely demystify the HAS-BLED score to understand its true clinical and surgical significance. Plus, we'll uncover the most common traps clinicians fall into when applying it.
But before we dive in, I do need to issue our mandatory disclaimer. The content in this deep dive is for reference only.
Right, very important.
Yes. You must always follow local guidelines in your own clinical practice.
Perfect. So setting the stage here, the HAS-BLED score is ubiquitous. I mean, you see it in nearly every pre-op assessment for a patient with atrial fibrillation.
Yeah, you can't escape it.
But there's this massive friction point. It's widely used, but frequently fundamentally misunderstood by surgical teams as a strict perioperative bleeding calculator.
Or worse, a definitive reason to cancel a patient's anticoagulants.
Exactly, which it is absolutely not. Okay, let's unpack this. Because to understand how the tool is misused, we first have to look under the hood at how it's actually built, right?
Yeah. We have to step back and look at the original intent. HAS-BLED estimates the risk of major bleeding over a prolonged period.
How long are we talking?
Approximately 1 year. It's for atrial fibrillation patients on oral anticoagulants. It was developed to gauge a baseline long-term propensity for major bleeding.
A 1-year horizon. That distinction alone shifts the entire perspective.
It completely changes the context.
Because as a surgeon, your horizon of terror is usually the next 400 to 400 hours, not 12 months.
Exactly. So to bridge that gap, let's deconstruct the acronym. The H is for hypertension.
And we're talking about uncontrolled systolic, right? Like over 160 millimeters of mercury.
Spot on. That chronic pressure makes the tiny vessels incredibly fragile and prone to rupture.
Ouch. And then we hit A, which is a bit of a mathematical quirk.
It is, actually. The A stands for abnormal renal function and abnormal liver function.
Wait, so they are scored independently?
Yes. You get 1 point for marked renal impairment, like being on dialysis, and a completely separate point for significant chronic liver disease.
Wow. Okay, so 1 letter, potentially 2 points. And why do we care so much about the liver here?
Well, the liver is the manufacturing hub for hemostasis. With significant liver disease, you fail to synthesize coagulation factors. Plus, you often see secondary portal hypertension leading to thrombocytopenia.
Right, so they're factor deficient and lacking platelets. Bad combo.
Very bad. And the renal side of that A is just as tricky. Severe renal impairment leads to uremia.
Which messes with the platelets, doesn't it?
Exactly. The platelets might be their normal numbers, but the uremic toxins actively interfere with their function. They just don't stick to the endothelium properly.
That makes a lot of sense. Okay, so moving down, S is for stroke, meaning a previous ischemic or hemorrhagic stroke.
Because those vascular beds are already compromised. Then B stands for bleeding history, or a known predisposition.
Right. Next up is L for labile INR, and this is specifically for warfarin users, yeah.
Correct. It's for patients with a time in therapeutic range less than 60%.
Mm-hmm.
Their response to the drug is just highly erratic.
Got it. Then E is elderly, so anyone over 65.
Because of the natural decline in physiological reserve and vascular stiffness, yeah.
And finally, we have D, which, much like A, acts as a double category, right?
That's right. Drugs and alcohol. 1 point for antiplatelets or NSAIDs, and a separate point for excessive alcohol.
Because NSAIDs block that thromboxane A2 pathway, and alcohol just wrecks platelet production.
Exactly. So if you add that all up, the acronym has 7 letters, but the maximum score is actually 9.
9! That's wild. It's like a vehicle safety rating, really. It measures the baseline condition of the car and the driver, not the danger of the specific road you're about to drive on.
That is a fantastic analogy. Yes, it measures if the brake discs are worn down or the tires are bald.
Right. But what about the general risk brackets? How are they defined?
It's fairly straightforward. 0 to 1 is low risk, 2 is intermediate, and a score of 3 or more is classified as high risk.
Okay, and this right here is the major friction point. Because knowing that 3 or more means high risk, the immediate instinct for a surgeon might be to stop the anticoagulants.
And that leads to the most dangerous error in perioperative management.
But wait, play devil's advocate with me here. If I have a patient with a score of 4, wouldn't the safest surgical bet simply be to hold their anticoagulants so they don't bleed out on the table?
Absolutely not. And I strongly refute that instinct. The sources are very clear. A score of 3 or more is not an automatic trigger to withhold anticoagulation.
Really, never.
Never automatically. It means you need to address and review. What's fascinating here is how bleeding risk and thromboembolic risk are competing, but they are not interchangeable.
Ah, so you're talking about the stroke risk, like the CHE-Avasic score.
Exactly.
Yeah.
High bleeding risk patients very often share the same vascular comorbidities that give them high stroke risks.
Age, hypertension, stroke history, they literally overlap.
They do. So a high HAS-BLED score should trigger vigilance and correction of modifiable factors, not therapeutic nihilism.
No therapeutic nihilism. I love that phrasing. We shouldn't just abandon ship.
Right. You don't use a bleeding score as a reason to just drop their stroke protection.
So we have the baseline condition of the car sorted, but since HAS-BLED isn't a red light for surgery, we need to understand what it actually fails to account for in the operating theater.
Yes, the surgical blind spots are huge.
Let's list them out because they're totally absent from the score. First, the operation's intrinsic bleeding risk and the specific tissue plane.
Right. It also completely ignores emergency versus elective presentation.
It tells you nothing about the recent anticoagulant dose or timing.
Or the specific DOAC pharmacokinetics.
Yeah.
I mean, ipixaban is very different from dabigatran.
Totally. And what about neuraxial or regional anesthesia requirements? It misses that completely.
It does. It also ignores day of surgery labs, platelet count, fibrinogen, acquired coagulopathy, active cancer, sepsis. None of that is in there.
None of it. And here's where it gets really interesting. It doesn't account for the consequences of bleeding in a confined space.
Which is terrifying, really. A small bleed in a thigh muscle is one thing, but that same bleed intracranially.
Catastrophic.
Exactly. And this leads to a brilliant clinical paradox from the source material. A patient with a HAS-BLED of 1 can still have a massive immediate procedural bleeding risk.
Because they're undergoing, say, a complex spinal surgery or a major hepatopancreatobiliary resection, right?
Right. The procedure itself is the danger. Meanwhile, a patient with a HAS-BLED of 4 could undergo a low-risk procedure, like a minor skin excision, perfectly safely.
As long as their meds are managed, that makes total sense. So if it doesn't calculate surgical risk and doesn't dictate when to stop meds, how should the listener actually use it on the ward?
Think of it as a risk factor checklist. In the pre-op phase, you use it to systematically optimize the patient.
Like treating severe blood pressure if it's over 160?
Yes. Actively initiate therapy for that. Stop unnecessary NSAIDs, check their INR history, review alcohol intake.
But importantly, HAS-BLED does not determine heparin bridging or reversal agent choice, right?
Spot on. It does not decide those things for you.
Okay, so what about intra and post-op? If the score is high, what's the plan?
A high score means incredibly meticulous, careful hemostasis.
You're anticipating the ooze.
Exactly. And post-op, it means a much lower threshold for checking hemoglobin and renal function.
And I imagine you'd want prompt investigation of things like tachycardia or hypotension.
Yes, or expanding wounds.
Yeah.
You jump on those signs much faster.
Okay, but what about restarting anticoagulants after the procedure? When is the coast clear?
Well, if we connect this to the bigger picture, delaying therapy obviously reduces the risk of a post-op bleed, but it dramatically spikes the thromboembolism risk.
It's a physiological tightrope.
It really is. Anticoagulation should restart once adequate hemostasis is established, as per procedure protocols.
So it shouldn't just be an unexamined omission.
Never. It needs to be an explicit daily decision on the ward round.
Got it. Okay, so we've got a solid action plan. But even with that, there are lingering systemic traps that can catch a well-intentioned clinician off guard, right?
Oh, absolutely.
Yeah.
The biggest one is double counting.
Like with renal failure.
Yes. Marked renal impairment gives you a point on HAS-BLED, so you worry about the bleeding risk. But that same renal failure also alters DOAC pharmacokinetics.
Meaning the drug is pooling in their system because it's not being cleared?
Exactly.
Yeah.
Yet HAS-BLED provides no dose adjustment algorithm. Clinicians might note the high score, but forget to adjust the actual DOAC dosage.
Oh, wow. You acknowledge the risk on paper, but fail to manage the actual physiology. What about the trap with age?
Age is another one. Being over 65 gets you a point, but it shouldn't replace a proper frailty or falls assessment.
Right, because a robust 70-year-old and a frail 70-year-old are entirely different clinical pictures.
Exactly. This raises an important question regarding local guidelines, actually.
Which brings up the UK context, because NICE currently promotes the ORBIT score for AFib bleeding risk, even though HAS-BLED remains internationally recognized.
Yes, guidelines vary depending on where you practice.
So what does this all mean for the clinician listening right now?
It means local anticoagulation and perioperative policies always take operational precedence. You use HAS-BLED to inform your judgment, but follow your local directives.
It's a prompt for safer management, not a dictator of care.
Exactly. Which actually brings me to a final thought I'd love to leave the listener with, to mull over.
Go for it. Let's hear it.
If a scoring system prompts us to modify a patient's risk factors, like lowering their blood pressure or stopping their NSAIDs, does the calculated score itself matter as much as the clinical intervention it inspired?
Wow, that's a great perspective.
Are we treating the number, or are we finally treating the patient?
Treating the number versus the patient. That is a brilliant reframe to end on. Thank you so much for joining us for this deep dive.
It was a pleasure. Thanks for having me.
And to our listeners, thank you for tuning in. If you like this content, please don't forget to share it with at least one of your colleagues or friends to spread the word.
It really does help save lives on the ward.
It truly does. Also, be sure to check out our YouTube and other social media pages. And do check out our previous season and episodes. We've got some very relevant topics waiting for you. Until next time, keep looking beyond the numbers.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.